When next speaker is Dr. AAYESHA KHANUM.
In our study, we were trying to look at the efficiency in volume reduction if we inject ranibizumab or an anti-VEGF with higher molar concentration, which is brolucizumab, or if we use ranibizumab in combination with steroids. It's not moving. There is compression, there is endothelial injury, and that tends to start a cycle of cellular grade changes, which will secrete ICAM and other inflammatory factors which are responsible for the clot formation. And then there will be stasis hypoxia, which will further cause endothelial injury at large, and again have this kind of cycle in the rest of the part as well. So what I'm trying to say is that in occlusion, apart from anti-VEGF, there are other factors which can kind of be influential. That is the reason why we thought we can use a combination. So we used in one class we used anti-VEGF, which is ranibizumab. In the second we use a higher molar concentration, which is brolucizumab, and third we use steroid. So we were looking at what happens to the edema resolution, and secondary aim is how does the molecular factors change in the follow-ups. So we recruited 27 patients, 9 in each group. In ranibizumab, you can see that we gave the injection, and by next month the edema had reduced, and then we gave the injection, and by 5th month the edema was back. So over a period of 6 months, this patient ended up having 6 injections. I would call your attention to the VEGF-A levels. You can see that the VEGF-A levels was 390 to begin with. When the patient came back, because of the rebound effect, the VEGF level kind of increased, and then we gave the injection and we suppressed it again. It came to 311, which means that the hypoxia is not gone away. Now, similar kind of results were seen with brolucizumab, but in brolucizumab, what happens is the amount of suppression that it produces is a little higher. So the rebounds are known to see in a longer duration of time. That's why we did not see much recurrences in patients within the 4 months period. So these are the two brolucizumab cases examples where you can see that the edema went away and the patient kind of was okay by till up to 3 months. After 4th month, the patient kind of did not come back to us, so we don't know the status of the brolucizumab group. Now coming to the combination part, so what happened in the combination group was we chose patients and we gave anti-VEGF injection, which was ranibizumab, and we gave 1 milligram of triamcinolone acetonide. So you can see that although the patient started with something like 930 microns, by the first month the edema kind of went away, but there was still residual edema, so we ended up giving one more injection at 1 month follow-up. So first one was given in September, the second one was given in November, and that patient was okay till 5th of January, which means that within the period of 6 months, this patient, despite having very severe edema, only required 2 injections. And at 5th month follow-up and 7th month follow-up, you can see that it is fully resolved. So over a period of 9 months, this patient ended up with only about 2 injections of combined. So there's another case example, very similar case, which had almost 1 millimeter, 150 microns of edema. We gave combined injection in this patient as well, and the number of reductions were less. Again, if you look at the VEGF levels, you can see that the amount of suppression that the combined group generated was very high. You can see that it was 1100 in the case, and when he came for subsequent follow-up, when we looked at the VEGF levels, it was 22.8. So coming to the results, the mean improvement in the ranibizumab only group was about 9.5 letters. In the brolucizumab only group, it was about 11 letters. But in the combined group, they actually did well. The edema went away, and also with reference to the letter count, the patients did well. In the 9 cases that we included, about 4 cases required a repeat injection in ranibizumab group. About 1 case required a repeat injection in the brolucizumab group, and about only 2 cases required repeat injections in the combined group. In the central macular thickness as well, although our initial pre-injection CMT thickness was very high in the patients where we have given combined, you can see that the mean reduction was greatest in the same group as well. So if you look at the change in levels, you can see that the suppression of the VEGF and the ICAM actually happened in the combined group the strongest. So based on this, we can conclude that combining ranibizumab with a very low dose steroid can help in lessening the number of injections that are given to the patient, because other molecules are also at play, and steroid tends to inhibit those inflammatory signals. So this might be financially beneficial to the patient, and this can also help in what is called as the bespoke way of treating. But we still don't have a gadget which can actually tell us what is the exact level of VEGF. So that is something that one should work on and probably look into. Thank you very much.
So how did you decide that which patient should fall into which treatment group?
Actually, I would say there was a lot of bias, because when I started doing this study, because if you see the combined group was packed with patients who are having edema of between 900 microns to 1200 microns. So I began treating those patients initially, where I gave 1 milligram of TA along with the injection, and I saw that the results were better. That's when I designed the study. So in the combined group, I ended up including a lot of patients who had very severe edema. So although it's not randomized per se, but in patients who are having anything more than 600 microns in a vein occlusion, I would probably give a combined injection.
But you can see the percentage reduction in each group, no? So whatever is, that will remove the baseline
Yes,
difference.
ma'am. Yeah, it removed the baseline difference, but subsequently the suppression was also too strong. The VEGF signal was not there, like you saw in those two groups. So when we gave the combined injection, it almost shot down to subpar levels. I mean, it was not even 130; it was about 20 or 25.
The aqueous, the biomarkers that you did.
Yes, sir.
They are aqueous biomarkers.
Aqueous biomarkers.
Aqueous biomarkers.
Yes.
And in the combined one, so 1 milligram would mean 0.0125.
You also
ml.
get 20 milligram tricot preservative free, so that you can give 0.5.
So what is the total volume? So your either your
I gave-
ranibizumab would have been 0.05.
I did an AC tap, no, sir, to collect the aqueous sample. So in that way, I had neutralized the intraocular pressure.
Thank you.
Thank you, sir.